Dr. Tarek Muhammad Elshamy. Dr. Tarek is a pathology resident at Children's Cancer Hospital, and he is a teaching assistant at Faculty of Medicine, Badr University in Cairo. His presentation is entitled Detangling a Diagnostic Dilemma in Breast Biopsy, and it is under supervision of Dr. Zahra Al-Alfi, professor of pathology at National Research Center. Dr. Tarek, are you?
Is the presentation obvious to all?
Yes, I can see your presentation. Okay, it's all yours.
Hello, everybody. This case presentation is presented by me, Dr. Tarek Elshamy, under supervision of Dr. Zahra Al-Alfi, researcher of pathologist, National Research Center, Cairo, Egypt. First of all, I'm very thankful and grateful for Dr. Muhammad Kamal for such opportunity and for his professional organization of the event. Let's start our case, titled by Detangling a Diagnostic Dilemma in Breast Biopsy. Female patient, 69 years old, with left breast suspicious lesion and extensive microcalcification. This extensive microcalcification appears to you in the mammogram, which is very suspicious lesion according to the radiologist and the surgeon. But to us, not such important. It may be fat necrosis, by the way. Okay. Grossing of the specimen first grossing revealed multiple discrete rubbery grayish-white areas. Maximum dimension is 2.5 centimeter, and the first grossing revealed that there is no definite mass, which is very suspicious, so we have to do a regross for this case. After regrossing of the case, we found multiple suspicious lesions with rubbery to firm consistency, and all the suspicious lesions are sampled in histological blocks and revealed the following. First of all, what we see proliferation of the ducts with some sort of hyalinosis of the stroma. It's an adenosis and fibroadenomatosis and cystically dilated ductules. Here also a cystically dilated duct. And these are the extensive microcalcification which appears in the mammogram. And here we can find a sclerosing adenosis, diffuse sclerosed hyalinose stroma, entangling the proliferated ductules and the microcalcification. Also here, other slide revealed that there are multiple intraductal papillary proliferation as a duct papillomata, with other slide revealing usual ductal hyperplasia with haphazardly arranged cells and peripheral fenestrations like this. Atypical ductal hyperplasia with some sort of monomorphic cells. Also here. Other histological slides revealing a DCIS with its variants or histological variants like this. Prepriform pattern, comedo pattern with central necrosis, micropapillary pattern with tiny papillae inside the ductules, and a papillary pattern. Okay, our hectic question now is, there is any microinvasion or not? Help us. What about these tiny lesions? Are these a tumor pods or microinvasion? Or they are separate lesions? What about these? And also, what about these lesions? Okay, now we have to go with the immunohistochemistry for confirmation of the diagnosis. This is a photo of P53. We can see here the basal nuclear positivity of P53. We can go now with SMM for drawing the myoepithelial layer of the suspicious ductules, especially in this slide, this tiny foci, lined by SMM. Let's go with cytokeratin 5-6 staining and tell me how many patterns do you see in this photo? There is a pattern of positivity here, diffuse pattern. And here, basal pattern, other histological slides, reveals patchy positivity pattern for cytokeratin 5/6, also here. So these various patterns of positivity revealing to us that there are multiple lesions in this breast. We have now to go with ER, which is unfortunately negative for high-grade DCIS, but may take positive in some normal or hyperplastic ductules. So now it's obvious we have a final diagnosis for extensive ductal carcinoma in situ with no invasive element, high-grade DCIS with no invasive elements. Our differential diagnosis, that atypical ductal hyperplasia versus ductal carcinoma in situ, either no invasion or with micro-invasion. Okay, how to detangle these tricky entities? First of all, usual ductal hyperplasia. Usual ductal hyperplasia is a benign proliferation of the ductal epithelial cells in various patterns that may be solid pattern like this photo, or fenestrated pattern with this fenestra and haphazard cells around, micropapillary pattern with tufting of the epithelium. And now we can see this luminal characteristic, slit-like luminal arrangement around these slit-like spaces. And we can see also here around the spaces. And we can see what's called an epithelial prejudice of the epithelial cells. This is epithelial prejudice of the ductal epithelial cells. Okay, what about the cellular composition? We can see a very kind cells, plant cells that proliferated in haphazard manner. Okay, and they are not polarizing around the fenestra or the slit-like spaces. By immunohistochemistry, usual ductal hyperplasia show variable expression of ER and a mosaic pattern of cytokeratin 5/6. Okay, let's go with atypical ductal hyperplasia. Epithelial proliferation, very typical to low-grade DCIS, as the cells are monomorphic cells. Let's focus on these cells, monomorphic cells with well-defined cell boundaries. Counterpart in the usual ductal hyperplasia, there were no well-defined cell boundaries or called syncytial pattern. And here they are polarizing around the fenestra. Okay. And arranged in growth architecture like solid with fenestration or arcades like this. Or we have club-shaped micropapillae like this slide, or solid with fenestrations like this slide. Okay, diagnostic criteria of atypical ductal hyperplasia. We have now a very higher consideration of the similarity between the atypical ductal hyperplasia and the low-grade DCIS. Paper reveals criteria suggested by Page et al. Features of low-grade DCIS must be present in at least 2 separate spaces for DCIS diagnosis. But in case of, or according to Tavasoli and Norris paper, the lesion less than 0.2 centimeter or 2 millimeter with feature of low-grade DCIS are categorized as atypical ductal hyperplasia and vice versa. Larger than 2 millimeter classified as low-grade DCIS. Okay, what about the immunohistochemistry for atypical ductal hyperplasia? Strong and uniform expression for ER and lack of expression for cytokeratin 5/6. Let's go with ductal carcinoma in situ. Ductal carcinoma in situ have an important feature or sign in the mammography or the X-ray, which are the microcalcification, dispersed microcalcification. Okay, It's classified according to the histological pattern. يعني comedo DCIS with central necrosis, or crepiform DCIS like these features, micropapillary pattern, and papillary pattern. Also, don't forget that we have a solid pattern of DCIS. Okay, according to the classification, we have low-grade DCIS and high-grade DCIS. What's your opinion about this photo? It's a low-grade DCIS, similar to the atypical ductal hyperplasia, with monomorphic cells, well-defined cell boundaries or cell borders, and polarizing around the lumen, with foci of thermometers calcification. But in high-grade DCIS, we can see here the high pleomorphism, different shapes and views of the cells with pleomorphic nuclei, and we can see the atypia and prominent nuclei in some cases, with necrosis and high mitotic figures like these, frequent mitosis. And there is an intermediate grade DCIS which take features between the low grade and the high grade DCIS. Okay, what about the immunohistochemistry? In low grade DCIS, ER is diffuse and strong expression, ER and PR, and very rare or lacking HER2 new protein expression. But in high grade DCIS, ER and PR may be variable. Commonly, it's negative, but frequent amplification of HER2 protein, HER2 new overexpression in the cases of high grade DCIS. To summarize our notes, first of all, usual duct hyperplasia, heterogeneous cell population, number one, variable cell size and shape orientation, cell borders are ill-defined or syncytial pattern, and take many histological variants like solid or papillary, as we mentioned. Atypical ductal hyperplasia, cells are monomorphic and polarizing around the fenestrations or the slit spaces, and takes multiple variant histological patterns. And don't forget about Tevasoli, lesions less than 2 millimeters are considered atypical ductal hyperplasia, not low-grade DCIS. Here in the low-grade DCIS, we can see almost the same features of the cell and the architecture, but as we mentioned, more than 2 millimeters in size for each lesion. Okay, this table making a comparison between the four diagnoses, usual ductal hyperplasia according to the ER expression. Usual ductal hyperplasia was variable ER expression, atypical uniform ER positivity, low grade and intermediate grade DCIS, typically uniform ER positivity, and high grade DCIS, very rare or negative ER and PR with frequent amplification of HER2 new. Okay, this is an algorithm to evaluate any intraductal proliferative lesion in the breast. Step one, the first question, are there neoplastic cytologic features? If they are high or intermediate grade, considered high or intermediate grade DCIS. If there is low grade monotony of the cells, consider low grade DCIS or atypical ductal hyperplasia. In case of polyclonal appearance of the cells, we have to consider the usual ductal hyperplasia. Second question, or step two, are there any neoplastic architectural features? We have rigid bridges, club-shaped micropapillae, crepiform, with polarizing of the cells around the space. We have to go with DCIS or atypical ductal hyperplasia. But if we have a flat pattern, considered flat epithelial atypia. Step 3 or question 3 is there is any extension? Evaluate the extent of the disease. If the disease or the lesion well developed and uniform and more than 2 millimeter, consider low-grade DCIS. If low or less than 2 millimeter, considered atypical ductal hyperplasia. If minimal extent, so we have to consider usual ductal hyperplasia or focal atypical ductal hyperplasia. So our take-home message, proper diagnosis is vital for proper growthing is vital for proper diagnosis and proper management. Your decision is very important, is a cornerstone of the case. So be careful and make it correct. These are our references. And finally, thank you all for your listening. Thank you for Dr. Muhammad Kamal and Dr. Zahra Al-Alfi for such supervision and time and effort. Thank you for all listening and goodbye.
Thank you, Dr. Tarek.